Here we go. All right, so I am going to present the critical review of genitourinary lasers and energy-based devices outcome data. These are my relevant disclosures. And again, just scouring the literature for all the evidence in this category and critically evaluating. So I'm going to take you on the journey and the evolution of lasers and energy-based devices for genitourinary applications, but most commonly genitourinary syndrome of menopause, but also some other applications in this sphere. It all started with Stefano Salvador's group in Italy, and I was involved, believe it or not, dating back to 2005 in the early research conducted in the United States, placing devices in GU offices, and actually it was my work that got the Mona Lisa predicate device, the SmartSide Dot, FDA approved in the United States. So I did the FDA trial for cutaneous application. So I've been in this industry for almost 20 years already, but his work was really the starting point for outcome data that motivated us to move forward on more clinical trials in this arena. His original study was 50 women, 3 treatments at 1-month intervals, and showed, using the VVA scale shown here, which is the most commonly used scale, improvements in the VVA scale and the vaginal health index. This was followed up and reproduced several times in additional studies looking at genitourinary syndrome of menopause. Here's another study, again, 3 treatments with fractional CO2, 20 subjects. But this one, he added pre and post biopsies for histology and was able to show connective tissue remodeling, increase in epithelial thickness, neovascularization. So he was able to do the clinical histological correlation between clinical outcomes and histology, correlating with improvements in vaginal health index and visual analog scores for GSM symptoms. Adrian Gaspar then did a randomized comparison of fractional erbium to estradiol, which really is the gold standard. If you're going to have a new treatment, you really ideally should do a randomized control comparison to the gold standard, which to date had been estradiol. And this was a really important paper at that time in 2017, 50 subjects, and comparing the fractional laser to the estradiol, he discovered that the laser treatment yielded superior improvements in the assessment of GSM for dyspareunia, irritation, dryness, and chronic leukorrhea. And what they also found was that these improvements continue to get better out to 6 months with a gradual return towards baseline after the 6-month period following cessation of treatment, and that these curves were reproducible irrespective of which whether you used the device or estradiol and then stopped it. The results basically would last and improve out to 6 months, and then you would get a recurrence of symptoms. I then worked with a colleague in a multi-site randomized trial looking at vulva and vagina treatment with fractional CO2 at VHI symptoms as well, using the VHI scoring, and also found and was reproducible improvements in elasticity, fluid volume, pH, epithelial integrity, moisture, and total VHI out to 6 months following 3 treatments. And just like my predecessors, following the 6-month, the 6 to 12-month time point, a gradual reduction in those improvements. These results were reproduced at both sites and were in close agreement. When looking at subgroup analysis, I then discovered that early intervention improves outcomes. The percent of subjects for whom normal or near normal VHI scores were attained was highly statistically significantly greater in the recently postmenopausal, the 1 to 3 years group, as compared to the postmenopausal cohort of greater than 3 years. This was a serendipitous discovery, suggesting that early intervention is correlated with improved outcomes. There appears to be a critical window where we need to act, so this increases the urgency of educating ourselves with respect to GU treatments, so that we do care for our patients to the best of our abilities before that critical window has lapsed and the tissue is appears to be less responsive. And not enough can be emphasized about the importance of the microbiome and pH. It is a chicken and egg phenomenon because there is a consensus that whereas pH and the lactobacilli population are inversely proportional, it is a catch-22 because the less of a glycogen content, the less lactobacilli you're going to have. The less lactobacilli you have, the more the pH will elevate, and the more you will have an overtaking of other species like Candida, which further reduces the lactobacilli population. So that correlation, that agreement between pH and microbiome really is at the crux of much of the pathogenesis of GSM. And it's a tremendous area of focus. And what we are discovering, and this is from Athanasiadou, is that if you treat with fractional CO2, not only do you have a restoration of normal pH, but you also have a restoration of the premenopausal microbiome and a restoration of the lactobacillus population. So I then looked at the pH following fractional CO2 and found indeed that after 3 treatments, and here I show baseline, after the second and third treatment, at baseline, we have a more alkaline pH postmenopausally that gradually is reduced towards premenopausal acidic values. That continues to improve out to 6 months following final treatment. It is recapitulating what we see in cutaneous applications of fractional CO2. That remodeling process that restores the lamina propria, restores epithelial thickness and premenopausal glycogen levels, slowly greater improvement in the microbiome and the accompanying pH. That continues post-treatment. But between 6 and 12 months, we see a gradual recurrence of a more alkaline environment. And what I think is important about pH is this is a quantitative endpoint. It's not qualitative, and it's far less subject to bias. I want to bring to your attention then photobiomodulation before we get into sort of meta-analyses. This is important, and I want you to just pocket this little piece of information. Right around that time, there were some scientists that were looking at photobiomodulation or low-level energy using probes for treatment, and I was really struck by the level of efficacy of photobiomodulation, not just clinically, but histologic outcomes using the same scales. Pretty impressive results utilizing a at-home, do-it-yourself type technology at low level. And you're going to see how this comes back to us as we analyze the data. I then studied an at-home infrared device and demonstrated in this study that was published that it maintains vaginal health outcomes utilizing the VAS and VHI scales for an additional 12 months following fractional CO2. In other words, following fractional CO2, we have, for example, a restoration of normal pH and other VHI facets, but if you utilize this at-home infrared device, these results are maintained for an additional 12 months before they start to recur towards baseline. Now let's look at some randomized controlled trials and how they have raised concerns and controversies. One was this JAMA article that came out in 2021, which was reputedly a randomized controlled trial of laser versus quote-unquote sham. In fact, it was 85 subjects of a mixed population, so it was not just postmenopausal patients. It was a mixed population including breast cancer, post-ovarectomy, medication-induced, as well as postmenopausal. And they used 40 watts, and if you would remember from our best practices consensus, the maximum power to be used with this fractional CO2 device is 30 watts. So the power already was exceeding standard settings for this technology. In addition, the sham treatment was a 0.5 watt power. And I just showed you that low-level energy has been shown to be efficacious. So this was not a true sham. This was what I call a low-level energy setting control with probe. And what they found was no statistically significant difference in VAS or VHI. I think this is really interesting data that suggests that perhaps lower energy settings may be as effective, maybe, as high energy settings. But what it did not support were the conclusions by the authors, which was that, lasers don't work, or that probes don't work. So another study looking at fractional CO2 versus this quote-unquote sham was 58, but they restricted it to a postmenopausal population. It was a homogeneous population, and they randomized 2 groups. In this case, it was a mixture of acceptable settings of 30, but some cases did go up to 40 watts. And they had a control at 0.5 watts, much like the JAMA study. And they looked at similar primary and secondary endpoints. What we found in this randomized controlled trial is that in the treatment group, there were several findings, including dryness, dyspareunia, the FSFI score, itching, burning, dysuria, and UDI were significantly improved, statistically significantly greater in the treatment group as compared to the sham group. But the sham group, which really isn't a sham, it's a low-level energy group, did also show significant improvement in dryness, itching, and burning. The changes were all greater favor for the actives group. Now, perhaps it's because the more proper settings were used in this particular randomized controlled trial, but yet it does support the notion that a low-level energy probe would work. This is another study looking at fractional CO2 versus a sham. Here, this was a sham control in that it was I believe in this case there was probe but no activation. So this is what I call a probe control as compared to a true sham. And I'm going to go through that with you guys. So basically there was one treatment group that received 30 watts, the acceptable level on the device. Another group that received probe, no laser, but there was no true sham that got nothing. So here we looked at the typical primary and secondary endpoints, and it was these were postmenopausal, so this was also a homogeneous population. And what they found was there were no differences in the primary endpoints. Both arms showed significant within-group improvements in VHI and VHS, but not between groups. So they also suggest in this case that the probe alone may have had efficacy, and it just sheds light on how important it is to also have a no probe control. That brings me to this really interesting study that I discovered, vaginal stretching. Here, 103 women, and indeed, this was for pelvic floor myofascial pain. It wasn't for GSM specifically. But here, it was vaginal stretch plus device as compared to vaginal stretch alone. And they looked at VAS scores as well as pelvic floor muscle function and urinary symptoms. And this is so interesting. They found significant improvement in both groups, no difference between the groups. Urinary symptoms also improved in both groups. So vaginal stretch alone, in other words, probe alone, was as efficacious as vaginal stretch plus near infrared for pelvic pain and urinary symptoms. This is important because we're starting to see that probing or vaginal stretch is important. Now let's look at fractional CO2 versus estrogen. This is another randomized study looking at the 2 groups of fractional CO2 versus estrogen cream, looking at VHI and FSFI. And here they found that the effects were greater in the laser than the estrogen group with respect to sexual desire, et cetera, and so forth. Very similar to Adrian Gaspar in that it appears that device seems to be superior to topical estrogens. This is another study of fractional CO2 versus estrogen. And here they also looked at histological analysis, which they showed the topical estrogen tended to present a higher maturation index. This is very interesting to us. We're now looking at other things besides clinical outcomes and vaginal thickness. We're also looking at maturation indexes and outcome now due to this study. Sexual function increased significantly in both groups. And the data suggested, however, that the laser therapy was indeed an effective method for vulvovaginal atrophy, but no significant difference in this case between the two groups. And now this study, and I think this is also speaks to the importance of a true control, was fractional CO2 versus estrogen versus lubricant. Also very important. They found in this case that fractional CO2 resulted in better short-term effects than those of topical estrogen or lubricant with respect to VHI in postmenopausal women. So these groups need to be followed farther out. Fractional CO2 versus Kegel. This was for sexual dysfunction, and they looked at laser group with the fractional CO2 versus Kegel group and Kegel exercise. And what we found in this study, that the laser group was superior to Kegel for lubrication, satisfaction, and overall improvements in all the categories that were looked at. There are two important meta-analyses that were conducted. One was with 3,609 women, 59 studies were accepted into this analysis, and they concluded from this meta-analysis that radiofrequency and laser are indeed efficacious for the treatment of vaginal laxity and or atrophy. So this was the first important meta-analysis that has been done. And the other important meta-analysis, this was 64 studies, and here they concluded that the vaginal laser seems to improve scores on VAS, FSFI, and VHI in genitourinary syndrome of menopause over the short term. And they do recommend, as do I, the sham laser control groups and more objective outcomes for the future. Another meta-analysis demonstrated 59 studies. I believe this was very similar to the prior, that RF and laser are efficacious for the treatment of vaginal laxity and or atrophy. Similar conclusions there. And now here are the fractional laser settings from our consensus paper. That show the optimal settings for ideal outcomes. I want to, just before wrapping up, mention vulvar lichen sclerosis, a very, very important condition for which a randomized controlled trial was conducted by Cherelle Iglesias, the CURL study, that has been concluded. And this is important because it sheds light on the importance of the microbiome, the pathogenesis of erosive conditions, and how I believe there is a connection with the microbiome, candida, chronic erosive infectious component, as well as the atrophy, and how there is this vicious cycle in terms of the pathogenesis. Because this RCT demonstrated a far greater improvement in the Skindex 29 score in the laser arm as compared to clobetasol. And this is really important emphasis for me, because this is an area where clobetasol just contributes to the atrophy. So I think that this is something that really requires a lot of our attention, and may be an indication that the FDA will clear prior to something like GSM, for example. And this is a fractional erbium YAG to clobetasol showing similar outcome, where it was statistically significant, greater reductions in itching, pain, ecchymosis, excoriation, and hypopigmentation in the laser group as compared to the clobetasol group. So in conclusion, treatments with lasers and energy devices have been applied to the vulvovaginal skin and genitourinary tissues with quantifiable, reproducible measures of vulvovaginal health, reducing atrophy symptoms and lichen sclerosis in randomized controlled comparison of fractional lasers to the gold standard of estrogen. Randomized controlled trials with established cohort population conditions, correct energy settings, and true sham are required. But there is potential efficacy for photobiomodulation, low light energy settings, and probe or vaginal stretch alone, which require further comparative testing to lasers and energy-based devices. And please, again, refer to the best practices consensus of established published protocols and randomized controlled trials, which were published in LSM. Thank you so much.